Tuberculosis, whilst a curable disease, continues to take its toll on communities worldwide. In 2022, the WHO estimated that more than 10 million people were falling ill with TB around the world. Key to improving these statistics are changes that can be made in diagnostics that will identify drug-resistant strains, something that is crucial to patient outcomes and public health globally. I'm joined today by Bernd Merkl, who's the Business Unit Director for Mycobacteria and TB at Bruker Microbiology and Infection Diagnostics, by Professor Stefan Niemann, the head of the National Reference Center for Mycobacteria and the head of Molecular and Experimental Mycobacteriology Group in Germany, and Dr. Friesen, the co-head of Diagnostic Mycobacteriology and the medical co-head for the National Reference Laboratory for Mycobacteria. Tell us about the role and the focus of the National Reference Center in TB diagnostics.
We are here located in a beautiful area, in a rural area in Germany. And this center here, the research center Borstel, is focused since the 50s on TB research and TB diagnostics. So here are more than 300 people who are working especially in TB research. And the National Reference Center is one part of this big research center. And we are focused, of course, on one part of our work is diagnostics. So we do diagnostic for patient and do patient care in Germany for around 13,000 samples per year, which seems not too much, but keeping in mind that Germany is still a low incidence country and focused on very complicated diagnostics, which many laboratories are not able to perform. And another part of our national and international work is, of course, capacity building. So we are working together with national laboratories, helping them to develop strategies for testing. And of course, more and more countries establishing testing methods, which we're going to discuss later on, to support especially countries with a high incidence for TB and especially for multi-drug resistant TB, so MDR TB, especially establishing molecular diagnostics to diagnose those patients faster. Another part, of course, is research. So research together with companies, testing and validate new methods, new tests within a routine setting with our samples, and of course trying to see which is helping our patients more, which is more likely to be introduced in a setting for patients, and develop more and more other tests, such as molecular tests, of course, focused on surveillance nationally and internationally, and many other things. What we have a system with 10 other doctors and discussing every week many patients who have severe diseases, STB or NTM, so non-tuberculosis lung diseases, how to treat and how to perform tests with these patients.
What challenges are faced in detecting and controlling TB transmission in high incidence areas?
So we do quite a number of studies in different countries to understand how the disease is spread currently. And what we observe is that in high incidence settings in general, there is a high rate of ongoing transmission of certain strains. So transmission is quite important. And transmission is always going from an index case to other persons, and one index case, if it's not detected, can infect hundreds of other people that then have a lifelong risk to get the disease. And one important component in the fight against tuberculosis is, of course, to find the transmitting index cases rapidly so that the ongoing transmission to other people is stopped. And that's one of the major challenges, is to find cases before they are able to transmit, or at least to limit the possibility of transmission significantly. And that's especially true in case of multi-drug resistant tuberculosis. And there we have a second challenge. So we not only need to find the cases, we also need to have a correct diagnostics, especially of the resistances certain patients have, so that we can initiate an effective treatment, because ineffective treatment would then lead to further resistances and also ongoing transmission, which is also something we don't want to have. What we know is that in general, we would say a culture positive tuberculosis is needed to transmit, but there are also examples that this must not be a patient that has symptoms already. So there is now a number of research studies are investigating what the proportion of non-symptomatic patients is towards transmission of tuberculosis. And obviously that's higher as previously estimated. And that brings us again to the point, what is our searching strategy? So how do we find cases? And currently in the majority of settings, we don't have active case finding. So what we have is symptomatic case finding. So patients fell ill and then they seek healthcare and then they are detected. But we learn in different studies that it may be more effective to have active case findings, so that you, for example, screen everybody that comes in a healthcare facility, or you screen communities to actively find cases with a simple enrollment test, and then you have a further diagnostic follow-up to see which type of disease that is.
Why is there a need for a faster and more sensitive TB test?
We want to find active cases, cases who might transmit this disease in the community. So what do we have? Very classical old method, the microscopy. Robert Koch already introduced to us and we developed, but still it's an old method. And it's particularly challenging because you need a very high load of bacteria to actually detect in the patient sample the bacteria. It's very high, and children, for example, never have a very high amount in their sputum. So you will probably, or most likely, not detect infected children when you just do microscopy. Culture, again, very old method, started in the 50s, in the 40s. We developed this test, we cultivated the bacteria, let it grow in vitro, and we can see actually growing. It's actually quite beautiful, see it growing on the plate and see what's happening, but it takes up to 8 weeks to let it grow, and then we just see, is it positive or not? And especially in high incidence countries, patients are getting lost in this time in their community, so they're gone, you can't treat them. So you have to find a test which is very close to the patient, which is fast, which is very sensitive, and which is very precise. So which method do we have? It's of course our classical PCR, and there's a lot of development going on. And there's a market lead over years for one machine, but we have to be more diverse in the community to break the monopoly on this tests, and to offer patients the best methods in their society and within the healthcare strategies for several countries. And this is what Bruker probably does, to see what's going on in the communities, what do we need, and how can we actually implement the test which is needed in this particular setting.
Is there a simple logistical way to close the diagnostic gap, or do we rely on new tests and new technology?
So there's a lot of research ongoing on the different angles of what we want to detect. So one point indeed is that quite a number of tests currently are done at the central laboratory level, being it national reference laboratories or other reference laboratories. And when you then, that always requires sample transport from rural areas to the centers where these tests can be done. And in quite a number of countries we work with, Mozambique is one, you have an estimated number of cases, and then when you finally see how many cases really get to diagnostics, especially drug resistance diagnostics, this is just a minority of them. So all of these steps need improvement. That is pretty clear. So we need to have an easy and cheap enrollment test. So we need to find the cases, and then as a follow-up test, we then need to find drug resistance as major determinant for treatment failure when we would use just normal treatment.
Yeah.
So I think these two steps are quite challenging, and especially in the countryside, in rural areas, to have the most accurate test for both is a problem. But there is a lot of research ongoing, and that's where we have to go.
What factors have contributed to the development of multi-drug resistant TB?
So resistance in general is a consequence of the bacteria to evolve and to adapt to a stress that we give to them. So here they either are killed by the drugs we give, or they evolve towards resistance and then escape the therapy. And in principle, that is something, these mechanisms is something we cannot avoid. This is also the reason why we normally have at least 3 active drugs in the regimen, depending where we are, that should prevent resistance evolution in a given patient. Still, in the past, when we observe resistance levels and link it with the time certain antibiotics were introduced, we can see in the field, so in bacteria obtained from the patients, that shortly after a drug was introduced, resistance in Mycobacterium tuberculosis obtained from patients living in that areas was observed. So that is true for streptomycin, for isoniazid, for rifampicin. And when combination therapy starts, we then also saw evolution of multi-drug resistant bacteria. So that's isoniazid and rifampicin resistance, and so on and so forth. And we now, with the new regimens that are currently given to the patients with drug-resistant tuberculosis, we now see already drug resistance to new drugs like bedaquiline that is already being selected in clinical M. tuberculosis strains. Problem with that is that once it is selected, it will not go away. So once a strain has got resistance, then it can potentially being spread to other people that are then directly infected with an already multi-drug or an extremely drug-resistant strain. And that's one of the major mechanisms driving the drug-resistant epidemic on the globe, is the primary transmission of drug-resistant strains. Then in combination with misdiagnosis, we see an always further evolution of additional resistances, because the diagnostics is always a little too late, and then the bacteria can rapidly develop by mistreatment or not effective treatments further resistances. So the majority of drug-resistant tuberculosis patients currently are getting on a treatment that is not informed by drug resistance testing. And that's especially true for the newer regimens. So for example, for bedaquiline, there's no easy molecular test available, except we would do sequencing, would use sequencing technologies, and phenotypic tests are also just recently being established and rolled out. So that means that the patients are treated blinded, and if there is already pre-existing resistance to other drugs in the regimen, then obviously bedaquiline resistance emerges quite rapidly in
Yeah.
patients, and that's what we see already in surveillance data, for example, from Southern Africa.
How have Bruker's tests evolved to keep up with multi-drug resistance?
Usually a PCR or molecular diagnostic test is used because these tests are, let's say, very rather affordable and deliver quick results with high quality. We try, or let's say there is a number of tests that are automated and are suitable for the peripheral level. These tests are used a lot. However, these tests have certain limitation when it comes down to detecting resistances. They are mainly focused on rifampicin resistance, which is one of the most important first-line drugs. However, if you follow this regimen, you would only detect rifampicin or rifampicin and isoniazid resistant mycobacteria, which means the so-called, when you're resistant to both drugs, then we're talking about the multi-drug resistant strains. But if you have then monoresistant isoniazid strains, you would just overlook them, and the people that have monoresistant isoniazid strains are basically wrongly treated. So we at Bruker have developed more sophisticated tests where you need a central lab infrastructure and trained personnel, but which are extremely powerful. They can not only detect Mycobacteria tuberculosis complex, but also resistances against the most important first-line drugs, rifampicin and isoniazid, in the same PCR reaction, or also resistances to second-line drugs, like the so-called fluoroquinolones or linezolid, which are very important drugs when you have rifampicin or multi-drug resistant bacteria. So what we have done is basically looking at detecting the mycobacteria as well as the most important resistances to certain antibiotics. This is very important because then when the patient gets the right treatment, this does substantially increase the likelihood of a successful therapy. And as Professor Niemann just pointed out, it also, when you give the right treatment, avoids the development of further antimicrobial resistances caused by wrong treatment decision. And these antimicrobial resistances are one of the biggest healthcare threats that we have.
Tell us how this new testing approach can help countries and individual patients.
Diagnostics is particularly important for a good decision for an individual patient. And as we know, not just with bedaquiline as a second-line test, but even when we look on rifampicin, we have this antibiotics since years and years on the market. But we just recently understood that our perspective on resistance on this particular antibiotics is kind of different, that we have to review and to see it new. And we see this not with rifampicin, but also with other antibiotics. So we as being in diagnostics research, we sometimes are kind of late to the party. But this is not because the researchers are lazy, because it's very complicated to understand the evolution, to understand what we are actually testing and what is the treatment outcome. So we need a certain amount of patients who are treated with these antibiotics, and we have to look into the genome and to look and to see what's going on there. And rifampicin is a very good example. So since years and years, patients are treated as a susceptible TB. This is the most important drug. And we saw, when we saw the genomic evolution and saw the genomics, that there are certain mutations in this genome who are causing resistance. And the patients are having an outcome which is worse than those patients who don't have this certain mutation. But when we look into the phenotypic, so-called phenotypic testing, so it's basically a liquid culture testing with a certain amount, one certain amount of antibiotics. If it's higher, it's growing, then you see it's resistant. When it's not growing, you see it's a susceptible case. And with this very certain mutations, you see that the strains are not growing in this certain amount of, we call it critical concentration. So we think it's a susceptible strain. And normally over years and years, we tested just with this phenotypic testing. And we overlooked many resistant cases. And at some point, I think since 4 years, we lowered the critical concentration. Imagine, it's just 5 years ago. So over the last years and years, we overlooked those patients. So we need rapid diagnostics, especially for rifampicin, to diagnose those patients faster and offer them a better opportunity for treatment. So we can treat them with the BPAL-M regimen, which was endorsed 2022 by WHO, and decide for them, okay, now we have to start now and not in 4 weeks. The outcome is much better when you look on the data from TB practical patients. Have outcome of 90%, the good outcome. So it's very successful. And even probably as much important as on an individual level, the patients are not transmitting those particular strains in their communities and can be treated faster, and you can save other lives. So I think this is very important that we implement rapid diagnostics everywhere.
Are these new tests used globally in pilot studies, and are they being implemented in real-world settings that gather data to assess their effectiveness?
I mean, if we step back a little and look what resistant means, also as Inna already lined out, and what we need to detect, then we have one situation that is, for example, for rifampicin, where the majority of mutations are in one gene, in a short region, which can be easily or more easily accessed by rapid tests, because the mutations are not very complex and that region can be easily investigated. When we look into other drugs, and that's already true for older drugs like paracetamide or newer drugs like bedaquiline, there are hundreds of variants involved in resistance. And the complexity is even a little higher because not all variants found in these genes lead to the same level of resistance. And that's may give, what Bernd already also mentioned, may give us a possibility to even use high dose treatment to overcome resistance that is caused by some of the variants. So what that means is that for a rapid molecular test of all of that information, we would need to have a test that is based on sequencing. And that test, these kind of tests have been developed, so we can do a so-called targeted sequencing assay where a certain number of resistant genes is amplified and then sequenced in smaller sequencing instruments. And these tests have also been brought to the market. They have been endorsed by the WHO, and they are currently also already applied on the reference laboratory level in high incidence settings with good results. So we can implement those technologies, and they can be used for the rapid and very comprehensive resistance testing. Still, one must say that the technology overall is for sure too complex to be rolled out in the periphery, so in smaller laboratories. And I would also think that yes, we are in the pilot phase, and the countries we work with are now integrating these technologies in their diagnostic guidelines. WHO has acknowledged the possibilities and has endorsed a mutation catalog that we can use for data interpretation towards clinical decision making. And also the tests that are currently on the market are currently undergoing more in-depth evaluation of the WHO, and also recommendations will come out. So the framework is set. We also have already data from high incidence settings where the technologies have been applied successfully. But I must still say that the diagnostic chain that comes from enrollment and first diagnostics of a resistant strain or a resistant patient, and then towards this more complex diagnostic test needs to be fully established. And here the system from Bruker, for example, has the advantage that we can use the DNA of the first line detection system to do a follow-up sequencing approach when a resistance is detected. So I think that's one way how we can use efficiently the samples that we get, and then also get to more advanced diagnostics.
Please tell us what you expect will happen in the next 5 years.
So I must say that for me, I'm a genome sequencing person since 20 years. And since 20 years, we are fostering and trying to get sequencing technologies for rapid drug resistance testing or drug resistance diagnostics in place. What needs to change is, of course, we need to make it all simpler. And that's for the whole test chain. That's the data interpretation, that's the link to patient care, that all needs to come to a more easy workflow that can be easily handled in the countries where it's most needed.
I totally agree. I think that's the most important points. And then, of course, we have to look that patients, TB patients, are not just having a lung disease. Many of those patients having infections in their bones or in their guts. So we have to spread our diagnostics and lower our detection limit. So find those patients faster, even with a very low bacteria load.
Yeah, I think Professor Niemann and Dr. Friesen phrased it very well. I think there need to be improvements on all steps of the chain. Of course, we are talking here about diagnostic tools to improve the detection at the peripheral level, also sample collection at peripheral level, as well as faster and more precise tools for resistance detection at the reference laboratory level. A lot of efforts are undertaken here by Bruker, but also by other companies. But we should also not forget there is a lot of development in the drug pipeline. This is also very important because new therapies will provide alternatives to cure and help to treat the disease more effectively. And last but not least, what we also should not forget is that there is a number of vaccine candidates, meanwhile, also in phase 3, final clinical trial. And this would be definitely kind of a game-changing event in the fight against TB, as this would allow us to faster reduce the TB incidence and mortality. In the end, I think this all needs to play together. The diagnostic part, to have the right treatment, to have a fast cure with better medicines, but also, if possible, a vaccine to support all this to avoid that we have the disease. And I think this in a nutshell is what the community is pursuing together. And this is also very important, with better communication in the countries, with improvements on the infrastructure side and better access to healthcare. And I think this is the important thing what the global community needs to manage, to provide the support and the funding to stop that long-term killer tuberculosis by supporting all these efforts. It's not only one thing, it's a number of improvements that need to happen. Diagnostic therapy, vaccination, but also infrastructure and healthcare access.